Welcome to the CodeCast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the CodeCast podcast. My name is Terry Fletcher. We've actually hit episode 30 today, so I'm happy to say that we're moving right along, dropping every Tuesday as we promised you. And what we're going to talk about today is we're really going to look at some of the pitfalls that happens during an audit. Since I'm an auditor, as you know, not just an educator and speaker, I'm doing a lot of audits lately, mostly on the E&M side, but also looking at procedures as well. But we're going to focus just a little bit on the E&M side. And what I want to do is just show you some of the things that I'm finding. And it's been interesting to say the least. But we're going to focus on maybe a little bit of the history of present illness, and the chief complaint, and just really show you what could fail you an audit and then how to pass an audit, just to make sure you're passing and understanding the process. And I just want to give you some food for thought for today when it comes to E&M services. I do have a 3-part webinar series that is coming out in May and into June as far as how to choose a level of service. And I really understand that, you know, the levels of service have been out for the guidelines. The 1995 and 97 guidelines have been out for over 20 years now. But there still seems to be some misunderstanding in some of the elements and how to capture services and things like that. So as not to get into webinar format here, since we are doing a series on that comes with materials and everything, I just want to give you some food for thought, just kind of make an argument for you, let you know what I'm seeing, and then if you decide that you really want to expand on that into more of an educational process, please visit my website at terryfletcher.net, and hopefully we'll see you on one of our webcasts, because we really feel that this is important information. The physicians are under scrutiny like never before, and auditing is just happening. It's not if you get audited, it's when. And so I just want you to see from an auditor's perspective some of the pitfalls that I'm finding. But before we get started, as always, we want to thank our sponsoring partners. Healthcare Healthcare Executives Network is the fastest growing community for healthcare executives and their trusted partners. healthcareexecutivenetwork.org. Better Living. Since 2002, Better Living has been the premier digital lifestyle brand dedicated to travel, food, health, home, and more on betterliving.com. Okay, so what we're going to do is really kind of dive into this information. And I actually also, I don't know if any of you are familiar with something called ICD-10 Monitor. MedLearn Media put something out for that, and I'm on the board, on the advisory board, and then also a speaker on there. And it's called, they actually call it Talk 10 Tuesday. So a few Tuesdays a month, I get up really, really early since they're on the East Coast. And I have a segment that's with a bunch of also physicians and people from AHIMA and all over the country. And we just really talk about I-10, but we try to focus not just on some of the clinical processes, but also talk about coding and things, and that's my segment. And so I've also written a couple articles on this topic, and it's just been really in the forefront of my mind. I mean, I've never really wanted to be so heavy E&M, but in the last several years, that seems to be the focus where I'm at, even though as a multi-specialty coder, it's just interesting just really looking at this from an auditing perspective, and I wanted you to be clear on what some of the downfalls are, and I should say pitfalls, just basically what you'd be looking at if you got into an audited situation. And I understand physicians and extenders alike, they get busy and overwhelmed treating patients with ever-increasing volumes, and even with the assistance of what we call the electronic health record, or EMR, electronic medical record, deficiencies will happen. I believe it has to do really with lack of training, not just on the EMR itself, but on education on E&M, and really understanding the key elements necessary to not only support the code that you're trying to bill, but also understanding how those are pulled from that electronic medical record. In an open CMS call on March 21st regarding potential changes to E&M documentation, I heard many physicians of different specialties trying to make an argument that the history component of a medical record should be eliminated. And I was taken back a bit because the medically necessary reason the patient needs to be seen is really, this is the history portion. So it's the chief complaint. This is The reason that the patient, this is the reason that the physician can say, I can now move on with my service. And if you look at the history component of an E&M counter, this is where the medical necessity begins. It can lay the groundwork for the physician's right to move forward with the exam and medical decision-making process. And without a well-documented patient history, it would be hard to justify moving forward with any extensively documented record. There would be really no basis for it. Not only that, in both the E&M guidelines, the 95 and 97, they do require a history, beginning with the chief complaint, and that is really the reason that the patient's meeting with the physician. If there's no chief complaint or no acute or chronic condition that to be expanded on or that the patient is being seen for, then you're looking at a possible preventative service. And so let's talk about the chief complaint first, and again, just more of a discussion. So this is really a statement, typically in the patient's own words, such as my knee hurts or I have chest pain. And on occasion, it is the reason for follow-up, but if the record only states I'm here for follow-up, that's really an incomplete chief complaint, and I do see that a lot. And the auditor may not even continue with the record, and it could negate its value altogether. I know if I just say, or I just see patient here for follow-up, immediately I put that record aside and move on to the next one. If I don't see any reason for them to be there except for that, then we have in our latitude as auditors just to move on from the record, and that's unfortunate for the provider. So it's imperative for the provider to be specific in your documentation. For example, patient here for follow-up for their sprained knee, or patient here for follow-up for their hypertension, which is well maintained through medication. And that's another thing. If you're going to talk about chronic conditions in your chief complaint, which is allowable. I'm sure you've seen anything that is in a detailed or extended comprehensive history. You can list 3 chronic conditions, but something that always seems to miss that listing 3 chronic conditions is the direction that comes after that in most audit tools, and that means status. I have found that most physicians forget about that status and forego, the sign or symptom, but they just say basically they list what the patient's diagnosis is. So they'll say hypertension, hyperlipidemia, diabetes, and then that's it. And so that doesn't count as a chief complaint. It actually could also negate the record if it's not expanded on. So, for example, if a physician is going to document hypertension, diabetes, or let's say high cholesterol as a chief complaint, they would need to say something to the effect of hypertension compared to last visit is well controlled, maybe with ACE inhibitors and diet modifications. Give a type of diabetes, so type 1 diabetes, insulin dependent without complications, and the patient has been better about managing his or her sugars. Hyperlipidemia controlled, and then give the medicine if it's medicine related and medication related, and some mild diet and exercise changes. When the physician documents that kind of detail in the record, now myself as an auditor, now I have a better understanding of the total health picture of the patient without having to figure out how to search out the entire record. And now I can just focus on the encounter. You're going to have some auditors that will not search out the record. And so they will basically look at that and say, okay, well, I shouldn't have to keep looking for it. Actually had recently, not an argument, but a heated discussion about some chronic care management documentation where somebody basically said, well, didn't you interview the physician and also look at the entire chart on the patient? I was like, no. This chronic care management had this one charge for a 30-day period, so I looked at that 30-day period documentation and that documented record, including how to support that clinical time. And if it wasn't in there, you weren't getting it. I'm not going to go also interview the physician to get verbal information about what was or wasn't done, and then also the mid-level, and then also go back to, up to 2 years they were asking in the record to make sure that the entire record supported this one charge of a 30-day, 20-minute charge. And it's like, you guys you're missing something here with how this works. So you have to have that detail to be able to support when we get back to that chief complaint. When the chief complaint is a sign or symptom from the patient, the physician is supposed to ask questions to get a complete description and chronological account of the problem to be treated. So according to Medicare as well, and this is something you should know, the HPI, which is the history of present illness, that has to be documented by the physician, not by ancillary staff. So what I mean is your medical assistants and your RNs and LVNs, LPNs. So your backup staff, not your mid-levels, but your backup staff, When they're basically taking that review of system sheet and checking it off and scanning it into the EMR, that's okay. But as far as history of present illness, this is a detail in the record that the physician is responsible for. I see, as an auditor, I see very often, I see this being documented by medical assistants, and that's not appropriate. These are timeline questions that the physician goes through that may prompt a further discussion of a problem or may uncover potential underlying causes or conditions that only a physician's expertise can extrapolate from the patient. So ancillary staff can take vitals and enter review of systems, as I mentioned, but into a sheet, basically the patient filled out an inventory, but the HPI is the physician's responsibility. And when we talk about that, there are 8 components of history of present illness. Now, not to expand too much, to make this too much as a webinar series, because I really think that it's important that you would attend that with materials, but just to kind of give you where we're going with that, the 8 HPI components would be location, quality, severity, duration, timing, context, modifying factors, and associated sign or symptoms. And there's definitely definitions of those, which again get expanded once you take a webinar into that area. But when you look at that, the number of components documented for the HPI really determines the HPI level at either brief or extended. And brief really is what you're looking at if you're looking at anything on an established patient, which is a level 2 or 3. If you're looking at a new patient, you're looking at level 1 or 2. Anything beyond that, you have to get into extended. So how I would score a physician's HPI based on a chief complaint of knee pain, for example. So hopefully you can understand this. So brief, 1 to 3 HPI elements. Patient is here for knee pain, lasting 2 weeks. So knee is location, and then 2 weeks is duration. That's only 2 elements. That's all I got out of that. But here's an extended, and for an extended, you need 4 or more HPI elements. Patient is here for intermittent knee pain, lasting 2 weeks. She states it's a dull ache type pain that increases when she runs or stands for a long period of time. Okay, so that's really expanding that detail. And this can illustrate that leaving out important elements of the documentation could change a level of service, and you could lose revenue if you're not accurate. So think about that. Patient is here for intermittent, that's timing, knee pain, that's location, that's 2, lasting 2 weeks, duration. She states it's a dull ache type pain, quality, that's 4, and I actually stop at 4 because it's 4 or more. But also you have, when she runs for long periods or stands for long periods of time, that's a modifying factor. So now I have 5, and I do stop at 4 because you don't need it after that, and that just basically says that you're spending time auditing part of a record that you don't need to keep going. And so when you look at this, and again, this discussion is not to encourage adding these elements to increase the E&M level of service, but to really enlighten you and your physicians and providers and mid-levels that leaving out components of the history portion of an encounter or not taking the time to be efficient in your documentation can lead to failing an audit and inaccurate scores on audits. Remember, being audited is all about just scoring you. The auditor basically takes a look at it, and you get points and bullets and you get remarks for how you scored on the audit and what you've included that's pertinent to the problem, or at least directly or indirectly related. And you could possibly see lower reimbursements if you're not accurate or fulfilling those details. And, as auditors, we're bound by the documentation rules. It's not an opinion. Some things are a little bit subjective, but most things are objective, meaning that we go by a tool, we go by a guideline. And physicians need to be aware that those rules are for the protection not only of the patient in the completeness of the record, but also to assist the physician as a prompt during the encounter, so not to miss out on any information that may be directly or indirectly related to that encounter and help you support medical necessity. And so that's really what I wanted to take a look at this week, just so you had an understanding of how you could possibly fail an audit by leaving out just those little details on that chief complaint and a history of present illness. And again, we do expand on that when we get into more of our learning tools and our webcasts and our live seminars. So we want to get into a reader question today, as we always do, but before that, let me talk about one of our sponsors here, and that's Medical Office Manager. Medical Office Manager publishes a website and monthly newsletter featuring articles, customizable policies and tools, and more. Check them out as Office Manager, which is medicalofficemanager.com. And so as we look more at some of this information, it's interesting because I really enjoy auditing. I don't know if it comes across that way, but I really do. And I think that when you get into it, I don't just like it for what it is as far as to really educate and help physicians in the process, but I like it because I believe it enlightens the situation. It really gives physicians an understanding that this is what I need to do, and hopefully they develop really good habits about it, and hopefully then it kind of goes on from there. So we just want to make sure that we're developing good habits. So my reader question this week comes from a cardiology practice, and it basically says, and actually a general surgery question as well. The physician removed a non-tunneled central venous catheter through a subclavian vein and replaced it with a tunneled Hickman line for a 50-year-old patient. The physician inserted a new line through the same site. Is there a CPT code that describes replacing a non-tunneled catheter with a tunneled catheter? Okay, so in this case, you should report only the placement of a new line, which is the 36558. That's an insertion of a tunneled centrally inserted central venous catheter without port or pump subcutaneously, and it's over 5 years old. So for a replacement, CPT does provide 2 replacement codes for central line, but neither of these codes describe removing a non-tunneled and then replacing it with a tunneled. So the replacement codes are basically, the 36580 basically says replacement of non-tunneled in and out, and 36581 says replacement of tunneled, but you've got one of each. And then the removal, it also provides 2 codes for removing a central venous catheter with or without port, and with or without it could be central or peripheral. It could be tunneled or non-tunneled, but it doesn't have a code to describe the situation of the question asker. So non-tunneled, so here's why. Because CPT doesn't provide for the non-tunneled catheter removal, because these lines are intended to be more short-term, removal is really included as part of the follow-up to a procedure or as part of an evaluation and management service performed on that date. So in your case, I would really go back to just the insertion, which is that 36558 code. Because remember, the removal codes are only for tunneled services, either catheter or port. So you just want to make sure you're not over-coding that scenario. Sometimes that happens every once in a while, and we really don't want to over-code anything like that. So just keep those things in mind. So this week, I just wanted to really talk about just some things that are coming up, really kind of focus on maybe some food for thought when it came to the E&M service, and then give you just a little bit of kind of insight into what our webinars are and how we kind of break it down for you. And if you take any of the webinars when it comes to E&M services, and we have again a 3-part, we give materials to you where you can also present it back to your physicians. So hopefully you'll appreciate that about the information. And lastly, our last sponsor is due.com. Due makes it easier for you to get paid online, and due.com. So we want to thank everyone today for joining us, and we really appreciate you, again, giving us your iTunes downloads and Google Play, Stitcher Radio, TuneIn. Did I miss anything? You can also get it on my website. If you're on any of the applications that I mentioned, please rate us. We really appreciate those ratings. Hopefully you find that we're worthy of those 5 stars, because it keeps us on the air. So again, we really appreciate that. So everybody go out and make it a great day, and we'll see you next time on the CodeCast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1, or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.